Good afternoon, everyone, and welcome to the webinar that deals with the SARS-CoV-2 virus and the COVID-19 disease. We will just wait a few minutes to allow everyone else to join. We have more than 300 people who've registered, so let's give it a couple of minutes for more people to join. Right, good afternoon. Thank you, everyone, for joining. As you've seen on your screen before and through the invitation, we have some very exciting speakers lined up for the next 1.5 hours. A couple of housekeeping things before we get started. We have time allocated at the end for Q&A. So if you have some questions while the presentations are going on, please put them below in the YouTube chat, and we will try and address as many as we can at the end. The second, we have also received a lot of questions regarding CPD points. If you've registered for the event, the organizers will compile the list and you will get the points credited at the end of the seminar. So please don't worry about that. My name is Karan Kampani. I will be your moderator for today. Without much ado, I would like to kick off the session with a short introduction from Ms. Chai In Heng, the General Manager for Roche Diagnostics Malaysia. Ms. Heng, the stage is yours.
Hi everyone, good afternoon to all of you who have taken your time to join our COVID-19 session today. In January 2020, in the blink of an eye, COVID-19 pandemic has created global chaos, massive countries lockdown, throwing many of us into panic and anxiety mode, uncertain of what's really happening around us. Overnight, scientists, specialists, clinicians worked tirelessly around the clock trying to unravel and learn as fast as possible about the virus, hoping to find ways to control the pandemic. Innovation, speed, and technology has also made it possible for various manufacturers to produce tests within weeks to help the government perform COVID-19 tests as mandated by WHO. Today, I'm very thankful and feel privileged to have all our speakers who has also taken the time to share with us on what they have learned so far about COVID-19. Thank you, and I hope you will enjoy the sharing today.
Thank you, Ms. Heng, for the kind words. With that, I would like to introduce our first speaker and panelist, Dr. Kuljit Singh. Dr. Singh is the president of the Association of Private Hospitals Malaysia, the APHM, and medical director for Prince Court Medical Center. And he'll give us an overview on the hospitals and the situation with COVID-19. Welcome, Dr. Singh.
Thank you, Karen, and also thank you, Roche, in helping us organize this webinar. I think it has been almost 2.5 months, getting close to 3 months that we have been doing COVID in Malaysia and in the world. I think we are almost clocking in 6 months of this pandemic. And I think this is the right time for us to discuss at this point of time what we have learned so far. And I'm sure there's a lot more that we are going to learn out of this pandemic. On the hospital front, the public hospitals in Malaysia, they were run by the Ministry of Health and one university hospital. actually managed the COVID-19 pandemic exclusively. This makes us a little bit different than most of the other countries in the world. But far majority in the world, we see that it is done in multi facility method. But in Malaysia, and I think also in Singapore, this was exclusively done by the Ministry of Health, which gave us a lot of edge, and also we managed to contain the disease pretty well, because the methodology was to contain it at specific locations and hospitals. And there were selected COVID hospitals in the Ministry of Health that managed patients which were COVID. Now, the advantage of this is, one, we could conserve our resources. Number two, at the same time, it allowed better learning curves, because COVID-19 had a very steep learning curve that everybody had to adapt to a lot of new technology, new way of managing patients, which the generation of people today probably have not seen a pandemic of such nature in their lifetime. So the private hospitals did not take part in looking after any COVID patients per se. And I think that was a very good decision that was made by the government. But what the private hospitals in Malaysia did was that we offered our services and our facilities to decant patients from the government hospitals in case they would want to concentrate exclusively on COVID, so that we could look after the non-COVID patients. We got about 900 beds ready throughout the country to help the Ministry of Health, and we provided facilities and equipment to the Ministry of Health. We had given up close to about 70 over ventilators, which fortunately was not actually utilized, because the Ministry of Health in Malaysia were very well equipped, very well ready. But we still deployed our equipment to the Ministry of Health to use our equipment should the need arise. We even provided dialysis slots to patients, for non-COVID patients to come to our hospitals, in private hospitals, for almost cost price or maybe even free, in order to decongest public hospitals. And we had volunteers from the private hospitals. Many of our specialists were ready to go to the public hospitals to assist during the time when the peak of COVID was at an alarming rate. The numbers were at an alarming rate. So we find that one of the things that we learned from this pandemic was that the public-private partnership was very much possible. We divided our duties. The private sector knew what they were supposed to do, and the public sector concentrated on COVID. I think it worked out amicably well. The private sector was invited to meet the public sector in several occasions during the early part of the movement control order, and all of us were actually ready, and we were even ready to an extent that private hospitals were ready to take COVID patients if the need arise. So we have got private hospitals which had the equipment, we had the facilities, but that was the last resort, which we never went to. And I think that was something that, in my personal opinion, we really learned a lot from our experience. We pray and hope that we don't have a second wave or a third wave, and things seem to be calming down a little bit, not only the national front, but also internationally. We see the numbers are actually coming down. But we don't want to let our guard go, because we do not want to see things going back to the way it was. So I think there has been a lot that we have gone through. And I think in this webinar, we will learn a little bit more on what we already know. And I don't plan to go more in detail. I'm also eager to listen to the other experts who are in the panel today. And I think from the hospital front, I think that's what I can say up to now. Maybe during discussion, I can come back with more points if I have. Thank you very much, Karen.
Thank you, Dr. Kuljit. I really hope that this is the new normal in terms of partnerships between public and private, as you mentioned, and hope this can continue even beyond COVID. With that, I would like to invite Dr. Arasu, the Honorary General Secretary of the Malaysia Medical Association, to share his views on the GP's perspective during COVID-19.
Thank you, Karan, and thank you, Raj, for this opportunity. The GPs during COVID-19, actually, they've been playing the frontline health provider role since even before the first case was reported in late January. And then, we have well distributed 7,000 clinics in the country, and this is actually a pandemic. And then we were having and we do not have what do you call it? In the private sector is purely standalone, and then is self-sustaining system. Okay, basically we had challenges. Initially, we had challenges in terms of PPEs, face masks. Okay, and then of course the GPs were aware that the three main areas that we had to focus during the pandemic was that number one was that safe identification and assessment of possible cases in general practice. As everyone knows that in Malaysia, the GP sees a sizable number of simple acute illness from upper respiratory infections, and also like asthmatic cases, and also so on and so forth. And then this, while playing the central role as the front line of care, they also need to manage the overall needs of our patients, and also adapting to the new norm of consultation. Okay, we used to see patients in the consultation room, and some GPs choose to wear full PPE sitting in the consultation room. Some of us adopted seeing patients in the treatment room, wearing a face mask, face shield, and maintaining a distance of 1.5 to 2 meters, and then try to minimize the time taken during consultation. This was done. And then the infection prevention and control measures in primary care is paramount because we are one of the frontline health providers who are high risk because we see lots of upper respiratory infections, and then we have to examine them, lung infection, and then we need to examine the throat, and then now most GPs, we examine the chest from the posterior part possible. And then what MMA has done also since March itself, we have done videos and also given out information with pictures on how to maintain IPC at the GP setting. This has been ongoing. We update our website and then communicate with GPs directly. And then the other thing is that receive attention of their acute health problems. See, while this is ongoing, we do have sizable number of chronic health problems, mental health concerns, and also preventive care measures. So this is ongoing. So we do have some challenges in terms of our patients. So what happened was that many of the patients start calling us, and then we have been providing services, communicating with them. Since 80% of patients coming to GP clinics are actually our regular patients. So we do have a very good patient-doctor relationship. We've been communicating with them. We allow them to communicate with us while the clinic is open. And then we also noticed there's a drastic reduction in the number of patients. Okay, number one is because of the movement control order itself. Number two, they were fearful to come out. Number three, of course, they have been at home most of the time. So the simple acute illnesses was much lesser in that period of time. Okay, and then the roles that we played in terms of screening COVID itself. If you're looking at the guideline, we have been providing visual and verbal triaging at our clinics. We have posters to inform patients. These are the signs and symptoms. What should you do when you need to go to hospitals? So we have done that. And then referring cases when we suspect personal investigation in the consultation room. There are stringent protocols by the Ministry of Health. And these protocols, at times, the GPs can be exposed not only to the disease, but also can qualify as a close contact. And in return, the GPs or the staffs can get quarantined. And then when a solo practitioner, when their whole team get quarantined, they end up closing their clinic. And this will also end up in terms of running their practice itself is affected. And then the other thing is that we do see cases of patients who do not reveal their history of travel, epidemiological history, a close contact history, but upon coming inside, looking ill, and then later find out that they are referred to hospitals, and later we found out that they are COVID-19 positive. And quite a number of GPs were also affected by that. And in fact, it was reported by the Ministry of Health that 45 GPs were also infected with COVID-19. Okay, that shows. So in fact, many GPs, I would say, in this course, maybe 30, 40, 50 GPs were actually quarantined. More than that, more than 100 of the staff also were quarantined in this process of doing that. And of course, the GPs are also actively involved in the return of work using the RT-PCR. They have to go through a certification to do the sampling, and then for the viral transport media, how do you play the specimen, and also for the doffing. So these were the things that done by the GPs. Next, okay. And then what we need to know is that this is really an uncertain and challenging future. So basically, what we have been doing, the GPs have been doing, is that whatever the knowledge that we have gained through a duration of work with the Ministry of Health and also with the knowledge, we are now applying this knowledge and the experience that we have in this uncertain period and preparing ourselves for the uncertainty. This is what we have been doing. And the other challenge is that the huge amount of information coming every day, the news and advice about COVID-19 is very dynamic. And then what we are doing, we also try to update ourselves with latest informations, because we get patients who are coming with us. Yesterday was something and today was something. And then there's also confusion among the patients, employees, and public, especially when the government makes certain policies without proper consultation with the stakeholders, and then without understanding whether the viability, whether it's physical, whether it's, so that also causes lots of confusion and also discomfort among the patients. So next, last slide. What MMA has done is that we have done a lot of work in terms of helping the GPs, and also creating awareness via regular media release. And also there are also, like for example, there is a confusion about the usage of antibody rapid test kit. At one time the government said via closed circular they said can be used, and later came out that cannot be used, and now it's said that can be used for prevalence and surveillance studies. And apart from that, they are also faced by lots of queries from the employees themselves or patients. For example, I can give a classic example is that foreigners who are in Malaysia who wants to return back to the country. And some countries they said, okay, you can just get a letter from the GP, it's fine. Some countries they say you must do an RT-PCR before you go back. And there's some employers, they're quite worried if let's say if one of their employees are having upper respiratory infection given 2 or 3 days of MC, and they're going to go back to work, they want to make sure that they don't have signs and symptoms of COVID. So what MMA has done, we also engage a lawyer and then prepare a simple letter with a disclaimer telling that the patient does not have COVID-19 signs and symptoms, but while making sure the doctor is not caught medical legally. So what we have been advising the doctors that this is a very unprecedented time, and a lot of guidelines may change and may vary, but whatever we do, it is better for us to have a clear guideline from the Ministry of Health so that we do not expose ourselves to any medical legal issues. So moving forward, what the GPs would like the government to do is that probably something like what has been done in Singapore, whereby the GPs were playing an important role in the terms of screening using even RT-PCR being a sampling in a selected clinic. Probably is something that the government should also look into in the future. With that, thank you and stay safe.
Thank you, Dr. Arasu, and to all the GPs who have dialed in. Thank you for being on the front lines and treating patients in the uncertain times that you brought up. For those who've joined us late, thank you for joining the webinar on COVID-19 and what we've learned so far. Hope through the next speakers as well, we can shed some light on the uncertainties that Dr. Arasu raised in how we manage patients and also testing related to COVID. So with that, it's my privilege to introduce our next speaker, Dato Professor Dr. Noor Shahida. She's a clinical virologist and the medical director of 23rd Century International Life Science Center. Dr. Shahida will share the current understanding of the SARS-CoV-2 virus. Professor, the stage is yours.
Thank you, Karan. So, my presentations will be divided. Basically, as a clinical virologist, I'll be able to share some insights on the virus genome itself, the structure, and then the life cycle, and then more importantly, what it does to the human body and how the interaction between the virus and the human body ultimately leads to the consequences of the infection. At the end of the lecture, I would like to introduce the natural therapy, mesenchymal stem cell therapy that has been used in many countries now and is forthcoming in terms of clinical trials, and the use of it in one of the syndrome which is fundamental leading to respiratory distress syndrome, which is the cytokine storm. So can I start, Alfred? This is the severe acute respiratory syndrome virus, and if you can see, the shape of the virus is actually polymorphic, but basically it has crown or spikes on it, and thus the name coronavirus or crown-like. Next slide. Just to give an idea of the propensity of the infection globally, you can have a look here that the latest WHO figures from yesterday, the 2nd of June, the total number of infection is to the order of 6,194,533 confirmed cases. And remember, these are just confirmed cases, and right now, the idea is to realize that there's a huge reservoir that's not confirmed or not detected. And this detection is based on the current diagnostics that we have, basically amplification techniques, and maybe in certain areas where they want to look at seroprevalence, the IgM antibody. There's 376 deaths, 376,320 deaths, with an approximate mortality of about 3.4%. Now, the Ministry of Health has done a tremendous job. As of yesterday, I haven't checked today's numbers, but of yesterday, we have a total of 7,877 cases, of which the discharge is about 6,470, which means 82.14% of patients has been discharged. And of this, if you look at the number of deaths, it's about 115. So approximately case fatality rate will be about 1.46. Now, if you look at the map, the world map, all countries have been affected. Now, this is, next slide, please. This is a diagram showing that the first coronavirus infection was actually reported in 1960. And it was reported as a common cold. Basically, at that time, a lot of research was not directed to looking at its pathogenicity because it's just one of the causes of common cold. Now, since then, until 2002, 4 subtypes of the coronavirus were reported to infect humans. And these are the ones, you have the 229E, NL63, OC43, and HKU1. And they all produce infections of both upper respiratory tract as well as the lower respiratory tract, but uncomplicated. And these are sporadic, number of cases not reported, not certain in terms of the totality of it, as well as number of deaths. In 2002, marked our key understanding of the coronavirus with emergence of the first lethal severe acute respiratory syndrome. And that actually caused a lot of deaths, about 774 deaths, in total about 8,000 cases in 29 countries. Now, however, this epidemic at that time is self-limiting, and in a couple of, well, in about 8 to 12 months, it receded on its own. In 2013, we saw the appearance of the MERS coronavirus. It is novel in terms of it being seen in Saudi Arabia. Since then, the new coronavirus, MERS, has infected more than 2,000 cases and in 27 countries. In terms of number of deaths, till November 2019, about 858 deaths. Now, this infection is still ongoing, and it is because of the close proximity of the cases with the Midori camels. Now, we know now the COVID-19 in 2019 started in Wuhan, China. At the time this slide was prepared, 160 countries were involved, but right now, as you know, based on WHO figures, more than 233 countries are affected, with a tremendous amount of patients not only being hospitalized, but also in terms of death. So the interesting thing about coronavirus is it seems to be a little bit ubiquitous in terms of producing non-significant upper respiratory tract infections, and if there is lower respiratory tract infections, it heals after some time, there's resolution. But because of the proximity of the virus itself to its reservoir host and the intermingling between reservoir hosts and maybe intermediate hosts, the virus has, being an RNA virus, been able to jump from one species to another. Next slide. This is the classification of the virus. So the SARS coronavirus, now we're looking at the slide on my left, if I'm looking at the slide. The coronavirus belongs to the order Nidovirales, family Coronaviridae. It has 4 subtypes of 2 each alpha and beta coronavirus. These are the ones that can infect human. If you look at the diagram, you can see that the SARS coronavirus belongs to lineage B, the multi-infection lineage A, and the MERS coronavirus belongs to lineage C. Now, SARS-CoV-2 coronavirus 2 belongs to lineage B as well. Next slide. This is showing the genome organization. In virology, it is a single-stranded RNA genome, and it's a very large. It's in fact one of the largest RNA virus. It's about 30 kilobases in length. Is encoded in 2 big open reading frames. Next slide. This shows the genomic organization. So the genome encodes 2 large open reading frames, ORF1A in yellow and ORF1B in blue. This encodes 16 non-structural proteins, the NSP1 until the NSP16. These NSPs are processed to form a replication transcription complex, or RTC. Now, this is very important because this is the complex that actually produces more progenivirus because it's involved in genome transcription and replication. For example, NSP3 and NSP5 encode for papain-like protease, so the PLP, and the 3CL protease respectively. Both protein functions in polypeptides, cleaving and blocking the host's innate immune response. NSP12 encodes for RNA-dependent RNA polymerase, or RDRP. NSP15 encodes for the RNA helicase, that was NSP12 that encodes the RDRP. The structural genes encode the structural proteins, the spike protein, the star of all the envelope protein, which you see when you look under the electron microscope, that shows the appearance as a crown-like structure. And then we have also the envelope protein, which is the E protein, and then the membrane protein and the nucleocapsid protein. The accessory proteins, they are shown in gray, and they are unique to coronavirus 2 in terms of the number, genomic organization, sequence, and function. Now, the N protein is very important because it has been associated with the dampening of the interferon released by the immune system, which means that the role of interferon really is to protect uninfected cells. So when that is turned down or down-regulated, the viruses are able to actually infect the cells before that is switched on. Next slide. This is the life cycle of the SARS coronavirus 2 in host cells. We know from scientific literature, it's been established that there must be a receptor on the host cell before the virus can connect itself. Now, the receptor is the ACE2 receptor, or the angiotensin converting enzyme 2 receptor. The S-glycoproteins of the virion at the top left-hand corner binds to the cellular receptor, which is the ACE2, and then it enters the target cells through an endosomal pathway. So following the entry of the virus into the host cell, what happens is the viral RNA is unveiled in the cytoplasm. Now, there is a role for the cellular proteases in the cells to assist in this release of the viral genome. And then the open reading frame 1A and the open reading frame 1AB is translated to two big polyproteins called PP1A and PP1B. And this is cleaved by the proteases of the transcription complex. Now, during replication, the transcription complex produces a full-length RNA copy. This virus is called a positive sense RNA, which means it's ready to be transcribed. So the copy is produced by the RTC and used as templates for other full-length positive RNA genomes. During transcription, a nested set of subgenomic RNAs is produced in a manner of discontinuous transcription or fragmented transcription, which is really very interesting because production of this enables the virus to actually produce a lot of non-structural proteins later on. Even though these subgenomic RNAs may have several open reading frames, only the closest open reading frame to the 5' end, which is on the left side, will be translated. So following production of the progeny of the SARS coronavirus 2, structural proteins, nucleocapsid are assembled in the cytoplasm and in the endoplasmic reticulum and Golgi apparatus, and then butt off the lumen of the ER intermediate compartment. Viruses are then packaged and released through exocytosis. Once exocytosed, it's actually ready to infect other cells. This is looking at the reservoir host. The most involved carrier we know right now for human infections is the bat. So the bat is fundamental. Other animal reservoirs include the cattle, pigs, camel, mice, dogs, cats, as well as ferrets. All coronaviruses that cause epidemics are believed to be originated in bats. In most cases, the viruses are transmitted to man via an intermediate host. The SARS coronavirus started through direct contact, for example, in 2002 with market civet cats in Guangdong. The MERS are transmitted directly to humans from dromedary camels. And now the SARS coronavirus 2, which causes COVID-19, is suspected to have been emerged in the seafood market of Wuhan. The evolutionary analysis revealed that it is most similar to bat SARS-like coronavirus. And most reports believe it is transmitted to man via an intermediate host, which the first suspect are really the Malayan pangolins. Next. But much research needs to be done to elucidate that. I wanted to show this diagram because it shows the entry point. It's like a lock-in key. The viruses, the SARS coronavirus, the MERS coronavirus, the SARS coronavirus 2, have got the key and the lock are the cellular host membranes. So for both SARS coronavirus and COVID-19 virus, SARS coronavirus 2, they use the ACE2, and the MERS coronavirus use what we call as DPP or dipeptidyl peptidase 4 to enter the host cells. Once they are inside the host cells, most of the replication cycles are similar until the virus are bud out. But what they found is the propensity for SARS coronavirus 2 is very high in terms of its ability to bind to ACE2 receptor sites compared to the SARS coronavirus. So in part, perhaps this shows why the spread of the SARS coronavirus 2 is so abundantly fast. Next slide, please. This is showing the viral host factors that influence the pathogenesis of SARS coronavirus 2. If you look at the top left-hand corner again, the bats are the reservoir of a wide variety of coronaviruses, including the SARS coronaviruses. SARS coronavirus 2 may originate from bats or through an unknown intermediate host and cross the species barrier into humans. Virus-host interactions affect viral entry. and the replication is also affected by this. Now, the upper panel, the viral factors, the SARS-CoV virus 2 is an envelope positive single-strand RNA virus, as I've explained earlier. 2/3 of the RNA is located in the long open radiant frame, and it codes 16 non-structural proteins. The rest part of the virus genome encodes the essential structural proteins, for example, the spike proteins. Now let's look at the membrane protein, which is the M protein. This is responsible for membrane transport of nutrients to the virus, as well as the blood release and formation of the envelope. The N and E protein, they are structural proteins on the outside. They are also having some accessory proteins, and these are the ones, especially the N protein, that interferes with the host immune response. The other accessory proteins, functions of which are still to be worked out. Now, there are other unknown molecules other than the ACE2 receptor site that can facilitate the entry of the virus into host cells. Now, as I mentioned earlier, the outcome of any infection between the virus and the host depends on the interplay between the virus itself as well as the host factors and the immune system. So individuals, we find right now, individuals who are more susceptible to severe disease are the elderly, as well as those with underlying diseases. The CPE, or cytokine effect, and cytokine storm are sustained inflammatory responses, and this causes hypoxia, septic shock, and may be related to the clinical conditions that we see in COVID-19 patients. So there are underlying predisposing factors that actually causes dire consequences in patients who are infected. Please remember that majority of the COVID-19 cases something that's not remarkable. They get infected and they are discharged, and this accounts for more than 80% of the cases, except for those who are elderly with underlying health conditions that increase susceptibility, especially when they have comorbid factors like hypertension, chronic obstructive airway disease, diabetes, and cardiovascular diseases. The severe complications we know is respiratory distress syndrome, septic shock, metabolic acidosis, which is very hard to correct, as well as coagulopathy and multiple organ failure. Next slide. Now, this is showing you the tentative pathogenic mechanisms of severe COVID-19 infection. The mechanisms, other than viral factors and impaired immune system, contribute to this immunopathogenesis. In the presence of defective clearance, which means clearance of the virus or an impaired immunity, persistent hyperactivation of monocyte macrophage compartment predominates as a compensatory mechanism. Remember, there is a down regulation of the production of interferon. This in turn leads to overproduction of cytokines and chemokines. And the cytokines and chemokines alter homing of cells into the lung and other tissues, and epithelial and endothelial damage happens with overexpression of these tissue factors and persistent thrombophilia. Each of these biological changes, if you look at it, may be responsible for some of the pathological conditions we see. They are partially overlapping. These are the ones we see in COVID-19 patients at the cytokine release syndrome, the macrophage activation syndrome, the institutional pneumonia with acute respiratory distress syndrome, and the secondary lymphohistiocytosis. So impaired immunity, immune evasion, plus a lot of virus, high viral load, especially high dose in those who are already with comorbid factors, produces a lot of the consequences and subsequent multi-organ failure in a cohort of patients. Each disorder constitutes a final pathological pictures. Now, this is to also show the downregulation of interferon. In normal infection, the inflammation is recruited, and there is immediate, for other common respiratory virus, immediate increase in the production of interferon beta and alpha, but in COVID-19 patients, it is low. And this helps the virus to actually increases its infectivity and production of progeny virions. Next slide. This is the possible mechanisms of immune evasion. The possible mechanisms include those uh, who are actually individuals who compromise ability to mount efficient immune response. As mentioned earlier, old people, people with immunodeficiency, or certain individuals carrying certain HA alleles unable to properly present the virus to T lymphocytes. Now, the T lymphocytes are the ultimate immune response after the innate immune response. In addition, a high viral load also will cause the virus to be able to overcome the barriers of the immune responses. Notably, these viruses control the production of interferon 1 and infect cells of both innate and adaptive immunity as well by exerting a cytopathic effect. In turn, the compromised function of immune cells, as we can see here, inhibition due to cytopathic effect, and the impaired antiviral production of interferon 1 favor immune evasion, resulting in highly detrimental pathological effects of COVID-19 cases. So, perspective of the virus is a virus that's obviously originated from an animal. Here, likely candidate are the bats. And from there, through an intermediate host, it further produces the ability to be more virulent. When they look at the ability of SARS coronavirus 2 compared to SARS coronavirus, it is in multitudes higher. I wanted to have a look at the fundamental reason why there's a lot of progression in certain cohorts of patients to get respiratory distress and failure. Based on current knowledge, this is the cytokine storm. It means that it is dangerous and potentially life-threatening. Here, the immune-mediated events related to the response of the SARS coronavirus 2 and the role of chemokines receptor system is exaggerated. So there is an exaggeration of the innate immune system leading to actually respiratory distress and influx of a lot of the chemokines causes that as well. Next slide. For the second half of the talk, I wanted to actually share with you what our interests are here. And this is looking at natural treatments in the name of mesenchymal stem cells as potential therapy for COVID-19 patients, especially those with a stage 4 respiratory distress or even earlier in stage 1, stage 2 and 3 of the infection. You know, the main pathologic features of severe or critical COVID-19 patients is hypoxemia, diffuse alveolar damage with cellular fibromyxoid exudates and extensive pulmonary inflammation, edema, and hyaline membrane formation. Now, these pathologic changes are similar to acute lung injury, acute respiratory syndrome, and is also observed in SARS and MERS coronavirus infection. However, more serious inflammatory exudation and edema and cytokine in the cytokine storm and milder pulmonary fibrosis consolidation were observed in severe or critical COVID-19 patients than those in SARS. Mesenchymal cells have been, they originate from either bone marrow, fat, umbilical cord, placenta, or the tissues. They have abundant supply, differentiation, potential powerful immunoregulation, and endogenous repair mechanism. As one of the most widely studied adult stem cells in regenerative medicine, MSC produces meaningful therapeutic outcomes for the treatment of pulmonary, cardiovascular, neurological, liver, and kidney diseases. Fundamentally, is the immune regulation of the MSCs that assists in its function to suppress the lung-infiltrated cells and enhance the resolution of the pulmonary edema. The complete revealed mechanisms and critical role of MSCs as an anti-inflammatory agent should be explored in therapy for severe and critical cases of COVID-19. So there are some clinical trials as depicted by this table. I know it's a little bit small. It's kind of a screenshot from one of the papers. let me just share that the therapeutic effects of mesenchymal cells, or MSCs, on acute lung injury and graft versus host disease is already proven in many publications. Some Chinese research groups have triggered the clinical studies, and these are shown in the table. In the triggered clinical trials, the inclusion criteria for severe or critical COVID-19 include respiratory rate of more than 30 times a minute. They look at also the pulse oxygen saturation of at least at rest about less than 3%, partial pressure, PO2, FiO2 of less than 300 millimeters. These are some of the requirements. And we believe that MSC have a therapeutic effect for severe and critical COVID-19 patients. Now, according to WHO, the management of COVID-19 has mainly focused on infection prevention, case detection, monitoring, and supportive care. There is no specific SARS coronavirus 2 treatment recommended. There are many that's in form of trial. We go through a bit of the pharmacotherapy after this. Next slide, please. This is the proposed interaction. Excuse me, I need to drink some water. Remember, we're talking about the cytokine storm. So what we propose is the interaction of MSCs to actually downplay the innate immune response to prevent the cytokine storm. So you can see that here, it is able to reduce the plasma cell, effector T cells, NK cells, mast cells, neutrophils, and macrophages. In early cases, you have a lot of neutrophils and very little lymphocytes, and these cause the degranulation of mast cells and, of course, infiltration of NK cells that leads to the infiltrates that you see in severe cases of COVID-19. Next slide. So the role of MSC in cytokine storm, if the pathology is pulmonary lesion, diffuse alveolar injury, we have intervention, protection of the alveolar epithelial cells, improvement of pulmonary fibrosis and lung function. If the pathology is immune cell depletion, the intervention is remodeling of the immune cell subsets and function. Multiple tissue organ failure, serum enzymes showing elevated levels of aspartate aminotransferases. The intervention improves the microenvironment. And more importantly, it inhibits lymphocyte proliferation and regulates inflammatory cytokines from being overexpressed. Next. A little bit about pharmacotherapy. Almost to the end of the lecture now. Experimental therapeutic strategies attempt to interfere with different steps in the coronavirus replication cycle. So it's important that the life cycle has been worked out. Now, the life cycle shows various targets for potential drugs. For example, hydrochloroquine. Chloroquine can prevent entry into the cells. And also convalescent plasma, in addition to that, can interfere with glycosylation, enhance and block the receptor. Then we also have antiviral drugs and protease inhibitors that can inhibit viral replication, processing of viral proteins. These are, for example, remdesivir, then blockage of viral protein processing, lopinavir, ritonavir. And number 4 is what I've been talking about in terms of blocking the cytokine storm. There are trials I know that's being carried out now in certain areas called some using anakinra and also I think tocilizumab. Okay, so the release of virus and induction of cytokine storm is something that has to be dealt with in order for us to prevent the dire cases of COVID-19. Next. Last 2 slides in terms of vaccine development. Where are we? There is unprecedented need actually to manufacture and distribute enough safe and effective vaccines. And this is required to immunize actually huge and extraordinarily large number of individuals to protect the entire global community from continued threat of morbidity and mortality from COVID-19. Now, the global need for vaccine and wide geographic diversity of the pandemic requires more than one effective approach. Just now, Dr. Kuljit talked about the partnership between private and public. So over here as well, collaboration will be essential. And among the private biotechnology and the pharma, as well as the government as well. This is just to show the kinds of vaccine development using live attenuated vaccines, inactivated viral vectors, peptide-like, as well as RNA and DNA vaccines. But the general consensus is it could be a subunit vaccine that might work because we're looking at the spike protein, which is on the envelope, and the spike protein is the main component or the main actor in terms of combining to the ACE2. And maybe a combination to go together as well with N protein, which is the one that's responsible for immune evasion. There's a lot more to be done. As mentioned earlier by Dr. Arasu, a lot of information comes out nearly every day. It's difficult to tease out which are the ones that are of relevance, but suffice it to say that a lot of people are working together. And I think in terms of the positive side of COVID-19 and SARS coronavirus 2, is actually the coming together of various players, not only in a country, but also around the world. I haven't touched anything on diagnostics because Dr. Pei will be doing that. And with that, thank you very much for your kind attention. This is looking at the clinical phase vaccine candidates. So there are a few here, but all in phase 1. Thank you.
Thank you very much, Dr. Norshaida. It's incredible how complex the viral mechanism is. So thank you for sharing that information. After that informative overview on SARS-CoV-2, I would like to invite our next speaker, Dr. Bharat Pankhania, who joins us from the University of Exeter in the UK. Good morning, Dr. Bharat. Over to you.
Good morning, everyone, and good afternoon to you in Malaysia. It's my pleasure to share with you the epidemiology of the coronavirus, and I'm going to take you on a journey. Please join me and let us learn something about this new COVID-19 coronavirus. So I'm a consultant in communicable disease control. My bread and butter is infectious disease outbreak management. We have been dealing with this all our lives. I plan, I prepare, and I'm always looking at the horizon, scanning the horizon, looking for what is emerging next. And often people say to me, gosh, you're always looking for negatives. Well, actually, by looking for these negatives, these emerging threats to humanity, we plan, we prepare, and we try and mitigate and make our planet safe. So come with me on this journey about what we're going to do today. So what I'm going to cover today is, we'll talk a little bit about the origin of these viruses. Our previous speaker has already covered it, so I'll nevertheless just touch on it and then move on to save time. I will cover the time, place, persons. That's the epidemiology of it as far as we know at the moment. And then we will also talk a little bit about what it is that are pandemics. And then the global picture of where we are at the moment with the COVID-19. And then, of course, the control strategies. This is my bread and butter. This is the work that I do every day for the last 20 years. And then we will also talk about what we can do in the future, especially with regards to prevention. So here we are. This has already been discussed, but I just want to touch on it a little bit, which is what tends to happen is when we mess around with nature, bad things happen. And in this case, when you bring in a mammal such as the bats in close proximity and in large numbers to maybe a pangolin, what can happen is a virus that is normally resident in bats and has nothing to do with humans. It doesn't affect us, it doesn't cause disease to us, it doesn't do us any harm. It then creates a co-infection, meaning two infections. One, the pangolin has got infection A, let's say that for an example, and now it has infection 2, infection B, we call it. And then the virus can reassort. So it gets bits and pieces of A and bits and pieces of B, to make it very simple, and it can produce a virus C, which has now got components from the bat and components from the pangolin. And if it is infectious and disease causing, it may infect humans. And so it has now become from a zoonotic to a human virus. Next slide, please. So to discuss, now that a new virus has emerged, is this a pandemic strain? And I was talking about it many months before the WHO pronounced that this could be a pandemic strain. So I made headlines in the United Kingdom by saying, of course, this is a pandemic strain. Let us go through it. So, of course, this is a new strain. And because it is new, there is no existing immunity to it. And therefore, it is infectious to all humans. We have never encountered it, and therefore, we are not immune to it, and we can get infected by it. And of course, as we know, it is disease causing. It spreads pretty fast. In other words, it is a communicable disease. And one more thing, the infections are sustained. And when infections are sustained, in other words, people get infected and are transmissible and transmissible fast, we have all the ingredients, the recipe, we have the full recipe to call it a pandemic strain. Therefore, without a doubt, the COVID-19 is a pandemic strain. Can we just have a look at this slide just for comparison? So these viruses, the coronaviruses, have emerged, and we have in the past had SARS, which was in 2002, 2003. And the good thing that was able to be done with SARS is, number one, it was not as infectious in humans. And number two, good early public health actions managed to control it, keep it at bay, and then finally eliminate it from planet Earth. So it is a combination of good luck as well as good early public health responses of lockdown, control, testing, contact tracing, and eliminating it from planet Earth. With respect to MERS, it has emerged again from bats to camels to humans. It is still there. The thing that is in our favor is it is not very infectious. The thing that is not in our favor is if MERS were to become highly infectious, we would have a huge problem on our hand, because the mortality the mortality from a MERS infection is very high, almost a third. So 30% of people who would get infected with MERS die. So we don't want the MERS virus to mutate, to change, to adapt, to become highly infectious in humans. So we need to have that watchfulness with MERS. And then, of course, we come to our current pandemic, the COVID-19. And we have, as we know, it is very infectious, it is a pandemic strain, and it is generating cases worldwide. Its R naught, that is the reproductive number, is between 2 to 5. In other words, for every one case, we generate between 2 to 5 additional cases, and then they create more cases and more cases. So comparing COVID-19 with other infections, these are case fatality rates. Case fatality rates are, if you become ill with this infection, how many people go on to die? So comparing it with seasonal flu, for example, the case fatality rate is very, very low, about 0.1%. Then compare that with MERS, that's the last pie chart. The case fatality rate is very high, 34%. And then comparing it with SARS, the case fatality rate was about 10%. So COVID-19 case fatality rate 3.4%. It is very high. It is not like the flu. It is a lot more severe disease causing. So we need to remember this. Next slide. I'm going to go very quickly through the signs and symptoms. And the reason why I want to address the signs and symptoms with you all is that we started off by thinking there are limited signs and symptoms. In other words, a fever, 37.8 degrees centigrade, a persistent dry cough. And then we've learned a lot more about these signs and symptoms. We've got the shortness of breath, the cough, the difficulty with breathing, the extreme tiredness, the unexpected nosebleeds, and abdominal pain, kidney problems. Next slide. So in addition to the signs and symptoms, we are learning new things about the COVID-19 infection. We are learning that it has an effect on other organs, multiple organs, and we're learning things every day. So there appears to be neurological involvement. There appears to be a direct hit on the myocardium and the heart muscles, as well as the lungs and other organs. What we need to do as a result is have good, robust data collection and surveillance systems. The reason why I put these slides up is there is a lot to learn. And because there is a lot to learn, we mustn't lose sight of long-term follow-up. Therefore, patients who have had the infection with COVID-19 ought to be monitored long-term, because we will find if there are long-term sequelae to having had a COVID-19 infection. At the moment, it's too early to say. Similarly, we need to follow up mothers who are pregnant and their babies, because there's a lot that we don't know. Is there vertical transmission, i.e. a transmission of infection from mother to child? At the moment, we're not 100% sure if it is and what it causes. So next slide, please. Here, I just want to share with you the age groups that are most affected. To summarize for you, the younger age groups below age 40 appear to have a low case fatality rate, almost unheard of in little children, to young adults, to up to age 50, you seem to be protected. Having said that, if you have got comorbidities, immune suppression, diabetes, blood pressure, heart disease, you may get affected. However, as soon as you start reaching the age 50 onwards, we've accumulated pathologies as we go along, and having accumulated pathologies as we age, the COVID-19 coronavirus seems to affect people in the older age group quite dramatically. So if you are in your 50 to 59 age group, case fatality rate is starting to be about 1.3%. And then it jumps quite high suddenly to 3.6% if you are in the 60 to 70 age group, and then 8% in the 70 to 80 group, and then 14% in the 80 plus group. Therefore, the take-home message here is that the older you are, the greater the severity of the illness and the greater number of people who also succumb, in other words, die from an infection following a COVID-19 infection. Next slide. So now let us go on to what can we do, containment strategy. Where have we been? So this is where we have been. Let's just pause for a second, please. Stop, please, don't change the slide. So we have been here, and one person generated between 2.5 cases. And what we want to do is, next, please, next, please. So we want to reduce the number of cases being generated. We can reduce the number of cases being generated by having, for example, the lockdown, which is what we've had now. The lockdown reduces circulation of humans amongst other humans, and therefore the infection is suppressed, and by suppressing the infection, we reduce the generation of new cases. So at the moment, we are generating about 1.2. Next, please. And where we want to be is important. So where we want to be is we do not generate additional cases. In other words, the R0, the basic reproductive number, is reduced to below 1. And when you reduce the R0 to below 1, the disease dies away. And that is the aim, the hope, the ambition to get to an R0, the basic reproductive number, below 1 and kill the disease off. This is going to be a tall order as the virus is in widespread circulation throughout the world, and as a result, getting R0 to be below 1 is not going to be easy. Next slide. So stop there. Let's have a look at this graph, and this tells us diagrammatically the issues with controlling an epidemic, in this case, the pandemic. So the blue curve tells us that with the rising number of cases, once you cross that dotted red line, it tells you that your healthcare system has been exceeded. In other words, you've gone over the capacity to treat people. So what you do with respect to controlling the epidemic is we want to flatten the curve. By flattening the curve, what we mean is that we want to bring down the number of cases over a period of time down so that the hospitals are better able to manage the people who are going to need hospitalizations and care. That is what we call the flattening of the curve. In other words, reduce the number of people over a given period of time becoming suddenly ill. Of course, the red arrow is you could also start to increase healthcare capacity, increase the number of hospital beds, build new hospitals like they did in China. That is a difficult operation. So as a strategist, red is difficult, almost impossible in poorer countries. Blue is possible. So our strategies, as you can now clearly see, are more blue rather than red. So let's have a look at this. The red curve over here is telling us that if you do nothing, next please. If you do nothing, you will get a peak in, so let's just go through it slowly. So we have red, which is no control. Okay, and then with the blue, which is weak control, and then green is the strong control. So the strong control represents China. China can do what only China can do. And then the blue one, a good example, is South Korea. They were able to identify, shut down places, contact trace, and bring the case numbers down. And then when you have no control, which appears to be what has happened in some countries, and I'm going to share with you my country, United Kingdom, as well in a minute. So when you have no control, you have a sharp rise in number of cases. When you have good control or strong control, you flatten the curve. That's the message I wanted to share with you today. Next slide, please. So here we are going to look at the number of cumulative, the cases throughout the world. And I want you to go home and look at the South Korean interventions. They did a wonderful job. And as a result, you can see that the South Koreans just flattened the curve completely and did a great job. On the other hand, for comparison purposes, the United States was late in coming to the game. And lateness is always an indicator of trouble to come. So you put in implementations late, you will have problems. So you will have runaway, lots of cases. And once you have lots of cases, very difficult to regain control. And you can see also United Kingdom was also late. And as a result of going in late, we are struggling with trying to regain control. Next slide, please. So here we are for the United Kingdom, and what I want to share with you here below is the green curve. The green curve is the number of new cases, and you will see with regards to our new cases, we are not dropping down despite having a lockdown, because our lockdown has not been serious, sustained, and very strict. So we are plateauing with our new cases rather than dropping down with new cases. The implication is that in the United Kingdom, we have got a lot of circulating cases, about 50,000 to 60,000 new cases every week. That is a lot of cases in the United Kingdom. And now with the lifting of the lockdown in the United Kingdom, we can expect more cases as a result of more cases already present before we started to lift the lockdown. Next slide. So here we are with regards to our COVID deaths, and you can see we reached a huge peak, and now having reached a peak, and we are leading in Europe with number of deaths, which is very unfortunate, very sad, and it is a clear example of what we can do if you intervene early, and intervene late, you've got problems. So we've had a record staggering number of deaths, especially in nursing and residential homes. Next slide. So I want to share with you this slide. This is very important slide. And when I refer to here as Africa, I'm referring to all poor nations of the world, South America, Asia, and Africa. And I'm using Africa as an example in this slide here. My message here with this slide is that if you do not control the COVID-19 globally, then you will get it becoming endemic. It will continue to circulate in the globe. You will continue to generate pulses of new infection, and as a result, it becomes an endemic strain and will keep on harming us as well as them. So it is in our own interests to control it in our community, in our country, and assist the WHO to keep it under control in the poorer nations with poor healthcare infrastructures. Next slide. So almost towards the end of my presentation here, we have already discussed options for the future, and we discussed the vaccine production. Coronavirus is an awkward beast. It doesn't induce immunity as well as we would like it to. We are not sure if coronavirus produces long-term immunity. Therefore, producing a vaccine, as we discussed in the previous presentation, is a tall order. It would be a miracle and wonderful if we can produce a vaccine, but we are not sure if we can make a vaccine. So what is the future? The future is we may find a medicinal cure. We don't know. So the only intervention left, the third picture here, is at the moment we can do social distancing, wash our hands, keep clean, and protect ourselves from getting infected, because we have no vaccine at the moment and we have no therapeutic medicine at the moment. Next slide. So what we can do here, this is the future. The lessons from history are we forget our lessons. So prevention is the best method possible, and we need to act hard to prevent, because prevention is a lot cheaper than the cure. If we change our practices and stop going into the ecology of animals, wild animals do their best to run away from human beings. Therefore, us human beings ought to leave wild animals alone. But when we start making incursions into their territory, we can expect problems. And we've had problems with SARS, which was a civet cat that brought into humans. And now we've got problems with coronavirus COVID-19. We've got problems with MERS, and we've got problems with antimicrobial resistance and all those things. The message is prevention costs you millions. If you refuse to do prevention because it's not sexy enough for you, then you will be fighting it, and it will cost you trillions upon trillions upon trillions of pounds, dollars, shillings, whatever currency you want to call it. So prevention is much better. Our energies should be energized towards causing less infection by less interventions in messing around with planet Earth. And that's my next slide, please. So I've got some links for you, and on these links here, the first one is you may follow me and get updates on Twitter. The second thing is, the second bullet point is, there's a myth-busting YouTube video on the common myths about about the coronavirus. And the third bullet point here is several media interviews I have given about the coronavirus, and they're all educative and useful for you. I will stop there. Thank you very much.
Thank you, Dr. Bharat. Very interesting to hear what has been going on in the UK and across the world. Thank you so much for the insights. Our last speaker for the webinar today is Dr. Pei, who is with Roche Diagnostics, based out of Singapore. Dr. Pei will give us an overview on COVID-19 diagnostic testing. Over to you, Dr. Pei.
Hello everyone, good afternoon. My name is Bi Kiao. So I'm from the Roche regional team based in Singapore. So today's sharing is going to be very scientific because it's like, we have to follow international guidelines regarding COVID-19, and also I will include some best practices that we learn from countries. Next, please. I believe Dr. Shahida has already introduced the structure of this, so I'm going to skip this. Next, please. So for a patient who is, for an individual who is exposed to the SARS-CoV virus, there is an incubation period of between 1 to 14 days. That's why for people who are in close contact with SARS-CoV patients, they have to serve a stay-home notice for 14 days. So when usually the patients start showing symptoms at maybe around day 5, so that's when it's like they felt sick and will go to the doctor to get tested. So when even before this happened, their body has already started replicating. The virus is already started replicating in their body. So when they go to the doctor and tell them that, okay, these are my symptoms, then the doctor may collect a respiratory specimen, usually from the upper respiratory tract, like the nasopharyngeal swab or the throat swab, depending on what is the recommended specimens that the clinic is doing. So then it's like after maybe 2 weeks, maybe I think 14 days, then the body start making antibodies to fight against this virus. So this is the basis of RNA test and the antibody test that we are going to look at later. Next, please. So for COVID-19 testing recommendations, with regards to US CDC and the European CDC and the World Health Organization, the nucleic acid amplification test, or what we know as PCR, is the gold standard for diagnosing any patients having current COVID-19 infection. Next, please. So I understand from my colleague that these are the popular tests that are being used in Malaysia. So I've already segmented them into a few types. So the first one that I want to share is the 2 steps method. That means they have to go through an extraction and followed by PCR amplification. So you may be very familiar with the TIPMO bioassays that's actually supported by WHO. So WHO actually bought a lot of these TIPMO bio kits and give to countries to help them with to diagnose COVID-19. So this is actually a 2-step method, and then after extraction, it takes about 1 hour and 30 minutes to give about 96 results. So another 2-step method that we know is Seegene from Korea. So this is also very similar to the TIPMO bio method, and it gives results in 1 hour 15 minutes after extraction. So another type of method that we know of is the sample to result method, which is our Roche Cobas 6800 SARS-CoV-2 assay. So this assay actually can give 96 results in 3.5 hours, and every 96 results in every 90 minutes. So there's also other types that's being used in Malaysia, which is the cartridge base. So there's the Cepheid Expert Express that can give results in 45 minutes, and also the QIAGEN respiratory panel that detects the virus and bacteria together with the SARS-CoV-2 and give results in 60 minutes. So you can see that these methods are actually all very different. So for a laboratory that is doing low throughput screening, I think a two-step method is sufficient for them, because it's like if they are overwhelmed with samples, then they will not be able to handle the samples timely. But for a laboratory that is doing mass screening, definitely they would like to consider the Roche cobas 6800 because of the high throughput. It can give at least 1,000 results in 24 hours and minimum hands-on time. So for maybe triage of patients at the A&E, then they can consider these cartridge-based results because of the low volume, and they can also give results in 45 minutes or 60 minutes per sample. So we also understand that with the upcoming flu season, it is also essential for us to differentiate between flu and SARS-CoV. So actually, we are launching a new assay on our cobas Liat, which is also a molecular point of care, or what we know as the cartridge-based solution. So this actually can give results in 20 minutes. So in the flu season, I think it's very important to differentiate between flu and SARS-CoV. Yeah. Next, please. So if you ask me what is the clinical utility of PCR, I mean, it's in the guidelines that it is used to diagnose active infection, both symptomatic and asymptomatic. I know a lot of guidelines actually uses PCR to discharge from hospital. That means at least two consecutive sets of negative results collected 24 hours apart. But I understand that Malaysia has changed the guideline last week, that they will discharge patients after 14 days, even if they still test positive for the virus, and undergo home quarantine for 14 days. This is actually following a recommendation from the WHO, and also my home country, Singapore, has also modified their guideline that they will discharge patients after 21 days, but they also have to serve a home quarantine for 7 days. Next, please. So what are the factors that can affect the SARS-CoV PCR results? I mean, it's like from clinical experience, right? Definitely is specimen related, because if there's improper collection of the sampling, that means 2 liter patient materials has been collected, or it's like improper transportation of the samples, not transported while chill, or it's like when the sample reach the lab and there could be possible contamination or mix up because of the manual methods that's being used. And it's also related to the disease cause and the amount of virus. We know that the specimens that's collected very late or very early in the infection, they will have very low viral load, and also something related to the limit of detection of the assays. Although we know that PCR is the recommended and the gold standard for detecting SARS-CoV in patients, but then there's also slight variability, and also this is very challenging with the low viral load. Next, please. So for the SARS-CoV-2 infection, as I mentioned earlier, next please, Albert. Yep. So to detect the pathogen, to diagnose someone being actively infected, we will use the PCR and the antigen test, and this test has to be very highly sensitive, because we cannot afford any false negative results. Because any false negative results means we are letting the patient go back to infect their family or their loved ones or their colleagues. So, but to answer another question is like whether has someone recovered or has someone had a past infection, then we will need another type of assays, which is the antibody assays. So for antibody assays, it has to be very specific, because any false positive result will lead to the wrong assumption of convalescence or putative immunity. Next, please. So we have gone through the utility of the PCR. So now I'll just like to focus on the antibodies. So antibodies is used to measure past exposure, and also is like to determine the seroprevalence of a given population, like the virus circulation dynamics, mortality rate, and also surveillance for the immunity. So it is also used to complement NET in the acute infection, especially during the residual viremia, where maybe the PCR can give a negative result or discrepant result, and then antibody testing can be used as a complementary. So we think that the use case for antibody assay is definitely return to work or prevalence screening. Next, please. So the commercial assays that's available in the market, they are actually focusing on the anti-N antibodies and the anti-S antibody. So you may know that for most infection, IgM is the first antibody that appears, but that is not the case for SARS-CoV. So based on the literature, we also know that there are some patients where the IgG may appear before the IgM, or they may appear together. And also, right, the antibody levels may not be directly correlated with the clinical severity. So in this situation, maybe just a qualitative instead of a quantitative assay is good enough for clinical use. Next, please. So I also like to update regarding this WHO recommendation on rapid diagnostic tests. So from WHO point of view, right, rapid diagnostic test is only suitable for use in research setting, and they also do not recommend the use of antigen rapid test. So I understand from my colleagues that in Malaysia that an antigen test is actually being used right now. So based on our experience with influenza, also the US CDC recommendation on antigen use for influenza. So antigen tests, they tend to be highly specific, which means if it's a positive, it is likely to be a true positive. But if it's a negative, then the recommendation is to reflex to a PCR because the sensitivity is not comparable to a PCR. So that's why I think if you are using antigen test to diagnose your patient, maybe you should consider reflexing all the negative results to PCR. Yeah. Next, please. So another latest update from CDC is also on the antibody usage. So they also think that it's like there are a lot of assays in the market that says they can detect IgG, IgM, or they are just total antibody. So based on CDC, they think that there's no substantial performance advantage whether if these assays can differentiate IgM or IgG. And we also know that there are a lot of cross-reactivity with IgM, especially with the rapid diagnostic kits that has already invaded the market earlier on. So then also any patient who is tested positive by antibody, I think CDC recommend to prevent interaction to prevent further infection with SARS-CoV and also to return to normal work, which is back to work. Next, please. So I'm not going to Alfred, back. One more back, one more. Yes, thank you, Alfred. So I'm not going to look at the sensitivity of all the rapid diagnostic tests. So this is just all the instrument based antibody assays. So if you look at all the antibody assays, instrument-based antibody assays that's available right now, I would think that most of them have very good sensitivity. But if you take into consideration of the confidence interval, that may not be the case. So for the Roche Ellipsis assays, we have a sensitivity of 99.5, and Abbott's Architect is also about 100. So, but then a very important factor is like when you look at the sensitivity, I think the comparison time point is very different from most assays. Like for example, the Roche assay, we actually used a benchmark of 14 days after PCR positive. And then I think for the Abbott's assay, they use onset of symptoms, days from onset of symptom. That's why if you look at the surface value, just be careful of what you are looking at because you have to bear into consideration what is the point of comparison and also the confidence interval. Next, please. If we look at the clinical specificity of all these assays, I would think that they are all quite good because they are all above 90%. And then the best two in the market is definitely Abbott's Architect and Roche assays. So if you look at the Abbott's architect and our Roche assay, the main differentiator is the number of specimen that is being used to determine the clinical specificity. So architect is 1,000 odd samples and ELISIS is 10,000 odd samples. So by doing more samples, the specificity is definitely more reliable and trustworthy. Next, please. So to understand what is a test specificity, right, let me break it down into very simple math. So if 100,000 people who are screened, that means asymptomatic people who are screened. So based on a test with a specificity of 98.8%, this means that 1,200 people may receive a false positive result. So if you look at our ELISIS assays with a specificity of 99.8%, so if 100,000 people are being screened, it's only likely that 200 people will receive a false positive result. So by a difference of 1% in the specificity, the number of false positive results can vary a lot. Next, please. So if we take into consideration of the disease prevalence and specificity of the assay, let me give you an example of the New York City where we know that the prevalence is about 15%. So with an assay that is 98.81 specific, so they may 1,011 people may be false positive, and the positive predictive rate value is 94%. But if you look at the ELISIS assay with 99.81, 161 may be false positive, and the positive predictive value is 99%. So this may not be very significant for areas with high disease prevalence. Next, please. But let us take a look at an area with low disease prevalence like the Santa Clara with about 1.5%. So if we do a testing there of 100,000 people, or with an assay that is 98.81% specific, 1,173 people may be false positive, but the predictive value of the positive predictive value of the assay is only 56%. However, if we look at if we try to do the same study again with the Roche ELISIS assays with 99.81, 1% higher, the number of false positive is likely close to 188, but the positive predictive value is going to be much higher and more reliable at 89%. So the specificity of the test with regards to the prevalence is actually very important to determine the false positive results and the predictive value. Next, please. So what we also know that is that there's a lot of unanswered questions regarding the use of antibodies, because the scientific community is also working on whether do these antibodies confer immunity, how long do they confer, and then when is the patient protected. Next, please. So other than the test that is being used to diagnose SARS-CoV and the COVID-19, there are also other tests that's being used to identify severe and critical patients. Like for example, the blood gas is being used for the acute respiratory distress symptom, and the IL-6 to predict the cytokine storm, and the PCT whether the patient is likely having a secondary bacterial infection, or the troponin T, the NT-proBNP, for prediction of the myocardial injury. So other than having solutions to diagnose a COVID-19 patient, we also have solutions to manage the patient during the disease course. Thank you very much.
Thank you, Dr. Pei, for the excellent overview on testing and what we should expect with PCR and antibody testing. With that, I would like to say thank you to all our panelists and speakers. We're about 4 minutes over, but I think there's been a few questions coming in. So without wasting much time, let's take a few questions, and I just open the floor to all of you. I've just tried to combine all the questions into a few key themes that have been popping up. The first question was just regarding symptomatic and asymptomatic cases. So according to KKM data, more than 80% of positive cases are asymptomatic, how long do these people remain infective, and what is the best way to prevent cross-infection from such individuals? Maybe Dr. Kuljit or Dr. Norshaida, what's your thoughts?
I think now there are a lot of different guidelines that have come out. It is actually a little bit difficult if the MCO is released. Then it's going to be a little challenge, but we cannot have an MCO throughout our life just because COVID-19 has not gone away. So you're talking about reinfection. I think it's a little bit tricky, but I think like what Dr. Bharat said, end of the day, we still have to go back to the norms of washing hands, masks, social distancing. I think that would be the best way. Dr. Nur Shaida, you got anything else to add?
Yeah, as with all virus infections, so we have the primary defending mechanism in the body, which is the immune system. What we're saying in COVID-19 patients is there's an exaggeration of the immune system, and this seems to compound worse in patients with comorbid factors. So those who are, the majority who are asymptomatics are not within these patients with comorbid factors. One would think that if the immune system is acting in a normal fashion, the virus is eliminated very quickly, even though it's more infectious in terms of the SARS coronavirus 2, its propensity to actually couple or enter the cell compared to SARS coronavirus is multiplied by many factors. A young person, for example, reasonable health and immune system that's intact will be able to counter the virus. And it becomes like an asymptomatic infection, subclinically and not clinically observed. But as Dr. Bharat has said, if you have a context in the context of contact tracing of a case, and then you have the family members who are asymptomatic, a PCR is a good method to test because initially the viral load, if they are away within the week of infection, will be quite high, so it's positive. Now, the downside is this: if PCR is positive, are they infectious or not? Because if you look at the detection method in PCR, some of them are detecting only the envelope protein. You need to look at the conserved regions like N protein, for example, or the transcription complexes. These are very closely associated with the virus. You need the virus to be intact in order for a patient to be infectious. How long will the patient be infectious? It actually depends. As I said earlier, it's an interplay between the virus and the host. And there's much more research that needs to be done.
Can I add, please?
Sure, Dr. Bharat.
So, with respect to our control measures, this is a very important piece of information. That is that a lot of people can be infected, infectious, no signs and symptoms. And as a result, the only control measure we have is to say to yourselves, and I remember making headlines in the United Kingdom when I said it, it is blindingly obvious, and yet it made headlines. And I said in March, consider everyone, anyone, every place as infected and infectious. And when you operate under that mode of everyone at any time, any place is infected and infectious, you will be more careful with not getting the spread of infection propagated. So therefore, in clinical settings, and I'm very concerned about my fellow doctors and healthcare workers, that they are, due to shortages of PPE, told this is a COVID patient, this is a known COVID patient. I say, for your own better operations, treat everyone as infected and infectious, and that way you will not propagate, not get infected, and not suffer severe consequences in a healthcare setting and out in the community too. Thank you.
Thank you. Just one other question on this that came in is, could the panel comment if there's been any cases of reinfection in Malaysia?
Honestly, I
Can
don't
I
think
give a
that-
general?
Go ahead, Dato'.
I'm not. I
So
mean, there were no reported cases that I have come to know that, unless I missed out, that there was any reported case of reinfection. But I think in the world we have heard other parts of the globe that there were many cases that were reinfection. Maybe Bharat, maybe you can tell us something on that.
yeah, so the truthful answer is we don't know, and the reason why we don't know is professor has already elucidated to it, is when you do a PCR test, are you identifying a active presence of the virus, or are you identifying viral RNA material or other as a proxy for the virus? One is a current infection, the virus is viable and infected and infectious, and the other is bits and pieces of the viral material which are not infected or infectious. So we don't know is the truthful answer, but what we need to be aware of is coronavirus is complex, and we don't know if it makes sustained long-term immunity to the infection. So the truthful answer is we don't know. We will find out in time.
Thank you, Dr. Bharat. Thank you, Dr. I think that's clear. I think we are all learning as we go along. Quickly shifting focus, there was one question on confusion regarding government regulations and how it went ahead without proper consultation. Dr. Arasu, can you just share some information or some examples for this?
Sure. In fact, MMA made a press statement on this. This is in regards to the return to work screening policies, where the policy was announced without a clear SOP from the relevant ministries, and also not understanding whether there's logistics to do the testing. And then eventually, first it was announced with involvement with one agency with a rapid antibody test kit, and then later they signed up the whole thing, and then they came out with another thing. So that has caused lots of confusion, and the general practitioners being the community doctors and very close to the community and also the workers. So the employers, everybody was calling to us, and then we were not able to answer any questions because why? We were also waiting for directives. So there were lots of confusion. So that is why in terms of policy making, it's very important for them to crystallize how they're going to implement, understand, work with the stakeholders who are doing the work on the ground, so that you will understand all the issues. At least you can minimize confusion and to minimize wastages. And in fact, MMA has made a statement on this 2 weeks ago.
Thank you, Dr. Arasu. And yeah, again, I hope that people can work together to really get the facts out and then make the right recommendations for everyone. Just one question on testing, Dr. Pei. The question on the chat was, there is a current issue with the possibility of false positives in rapid antigen COVID tests. Would you like to comment on that?
So, Karan, you're saying that there is a potential false positive result on rapid antigen test.
Yeah, this is what has been a comment in our chats, and there's a concern that there are false positives with antigen kits.
I think I'm not very familiar with the rapid antigen kits in the market right now, but it really depends on the sensitivity and the specificity of the test that's being used. So we also know that a lot of these rapid antigen or rapid antibody tests, they are not tested on clinical samples or very few number of clinical samples. So then there's the sensitivity and specificity that they claim may also not be exactly what the assay is performing. So I would think that to use this test for diagnostic, it is very important to do your internal validation to make sure that the test actually performs as it claims, and there's no cross reactivity with other disease or other interference, etc. So I think if they suspect there's any false positive result, it is worthwhile to contact the manufacturer and then work with the manufacturer for investigation.
Sure.
Can I Can I comment about false negatives, please? What I wanted to share with everyone is this is very important issue, which is a positive result tells us what we know, but a false negative rate of 30%. So in a clinical setting, we have got false negative 30%. This is exceedingly high. In other words, we must not rely exclusively on test results, because even in the best hands, clinical hands, we're getting a 30% false negative. Therefore, we should look for signs, symptoms, X-ray changes, as well as test results, rather than rely only on test results. This is very important for containment and precision of managing patients in a clinical setting.
So Karen, may I add? So if they suspect that the antigen is false positive, I think definitely it's worthwhile to double check with PCR.
Indeed.
Okay.
So I would like to make a comment in terms of the availability of test kits in Malaysia. You know that under Ministry of Health, the Institute for Medical Research is premier in terms of testing the kits. If you look at serological kits per se, they will have a panel of positive, negative controls as well to actually look at the performance. So in terms of the negative and positive predictive value, it has been the common practice that after evaluation, if accepted, then those tests can be marketed. I'm not sure whether I just want to ask Dr. Pei whether the Roche panel of tests have gone through that evaluation, as are the other panels, in terms of the serological testing and antigen testing.
I'm not very sure with the registration status in Malaysia. Maybe Karen can help me out with this.
Yeah, I would just say yes, Professor. The IMR goes through the evaluation process for all tests, independent of manufacturer, and even the antibody tests go through the same procedure, or will go through the same procedure.
All right. Now, the other thing is perhaps the Ministry of Health can come up with guidelines in terms of the acceptability of the results of the specificity, sensitivity, or the NPV and PPV in terms of the usage of the test. Because as we go towards into the pandemic, still we are looking at the elucidation of a seroprevalence. Now, the seroprevalence data is important, especially in the advent of having a vaccine, also in terms of accepting what level of sensitivity and specificity is the one that we can accept for our population.
I think Dr. Shalina, let me share with you, I think what happened to US. So initially they approved a lot of rapid antigen tests and antibody assays. So I think after a lot of backlash from the scientific community, they actually requested these companies to resubmit their data to show that they have validated with a certain number of clinical specimens, etc. So I think after this exercise, they removed quite a few kits that's available in the market for to use in US.
Thank you, panelists. Thank you for the good discussion and the points raised. In the interest of time, I think that's the last question that we take. Apologies to those who posted questions but could not get it answered. I think we will try and reach out or have another such a session where we can get answers. Once again, I take the opportunity. Thank you to all the panelists and speakers. Thank you for joining and sharing your perspective from a clinician point of view, from a GP, from a hospital, from a testing point of view. Thank you very much. With that, I close the session. And thank you to all those who've joined us on YouTube. Thank you for sharing the questions and comments. And hopefully you take something informational away with you from this. Thanks a lot.
Thank you.
Thank you.
Thank you.
Thank you.